everyone, and welcome to this, our fifth Maryland Rural Opioid Technical Assistance Project webinar in 2021. Maryland ROTA is part of the Substance Abuse and Mental Health Services Administration initiative. It is based at the University of Maryland and conducted in partnership with local and state organizations. Our PI is Dr. Jin-Hee Kim. My name is Erin Artigiani, ROTA co-director. Barbara Kerr, digital media manager, and I will be the facilitators for this webinar. Maryland ROTA aims to strengthen the capacity of rural communities in Maryland by helping our communities identify, understand, and respond to the evolving drug misuse crisis. Our multidisciplinary approach includes delivering evidence-based training and providing access to current information and local resources through the ROTA website, network, and webinars such as this. We encourage you to join our growing ROTA network to learn about best practices, access educational opportunities, ask questions of peers and experts, and share your local experiences. More information about Maryland ROTA and a link for joining our network are available on the Maryland ROTA website, www.marylandrota.org, marylandrota.org. This webinar explores the impact of stigma on negative attitudes toward opioid use and drug injection in rural communities. Today, we're very pleased to have you all here to join us as we hear from Dr. Jerel Ezell, Assistant Professor at Cornell University's Africana Studies and Research Center. This webinar will be approximately 60 minutes long, though we may go a little longer depending on the questions and discussion after the presentation. We encourage you to submit questions during and after the presentation. Please do not raise your hand though. Instead, we ask that you post your questions in the Q&A box, and we will hold a Q&A session after the presentation. We will do our best to get to all of your questions. A copy of the presenter slides and a recording of this webinar will be made available on the ROTA website, which again is marylandrota.org. You can find the webinar page under the Services tab. Thank you, and we hope you enjoy this webinar.
Great, thank you so much, Erin, for the introduction, and Barbara for helping get everything prepared. I'm just gonna go ahead and put up my slides. I'll give a little bit of introduction to myself, and then we can jump in. So, all right, excellent. So, Erin, thank you again for the introduction, and also thank you to Maryland Rural Opioid Technical Assistance Program and the team for the invitation. Appreciate the introduction that you just gave. There's not much else for me to add on there. I'm an assistant professor at Cornell that dabbles between sort of rural opioid usage, research, environmental health, and psychological trauma. And I'm really excited to present this project that I've been working on for the last 4 years that focuses on rural opioid use and drug injection, focusing in particular on the rural Southern Illinois community. With a big interface in terms of stigma and social attitudes and beliefs. So no conflicts of interest to report. You know, there's no Johnson & Johnson paycheck coming through, which would be nice, but no influence like that going on. This work is supported by the NIH and NIDA through 2 separate grants. So the first one, I'll just note briefly, was focused on really just this exploratory assessment of what are the risk factors for opioid use and drug injection in rural Southern Illinois. And then the follow-up grant that we have for this project has been focused on understanding more about how do we go about providing services. It's actually sort of a clinical trial in a way where we're trying to implement different harm reduction resources in an environment that it has a dearth of these sorts of resources. So this is going to seem like a sort of strange slide for me to present right out the gate, a little arbitrary and frivolous, but nevertheless, I'd like you to take around 10, 15, 20 seconds to look at this slide and just maybe to identify some patterns and get an idea of what's going on here. So I'm going to put myself on mute. We'll talk about this in a few slides, but just think about what's going on here as far as patterns and trends, and then we'll revisit this a little bit later. Okay, so let's move forward. Probably a bit of a trip down memory lane. For some of you in other of these movies, Particularly the ones that maybe look a little newer are probably completely jarring to you. But we'll get back to that in a little bit. So just an overview for this talk. Briefly, I'm going to cover what the opioid crisis is. We know a lot of the contours of this already, but I think it benefits us to have a little bit of a backdrop for this broader conversation. And then I want to split off into a discussion of two epidemics, the crack and heroin epidemic of the late 70s, the 80s, also going into the 90s, and to sort of compare and contrast that with our present opioid epidemic in this 21st century and in the 2020s. And then that's going to shift into a discussion of stigmatization in the context of this research that we've been doing in rural Southern Illinois. And this is the Delta Rural Health Study that is presented here in point 4. Where we're looking at views, perceptions, attitudes, and behaviors in relation to opioid use and drug injection in these communities. And then I would like to end with a brief breakdown, a meditation, some ruminations on implications for this sort of work in the realm of policy, also in the realm of clinical practice. And for those of us who are doing research, some implications for how we can advance research in this space in ways that feel substantive and applied. And this is going to transition or segue into a discussion of potential anti-stigma strategies. So I started this whole thing off, or the title of the presentation is it classic stigma or is it something else? So the something else part of it, right, is a hangover. They wouldn't have invited me if there wasn't that. So yes, there is something else in our minds, and we're going to get into that in a few slides. So some things about the epidemic that we already know, but are worth repeating, meditating on it a little bit. So we know that non-medical opioid use has risen quite dramatically in over just the past 2 decades, 2.5 decades, around 2.5 million people. And these data, as you know, are always in arrears. In the US have an opioid use disorder. This is sort of clinically defined. And in spite of some of the gains that we've had, at least in terms of reducing overdoses in certain communities, reducing morbidity, the trend itself, the culture, the zeitgeist, if you will, of opioid use has been pretty resilient against industry regulation and community policing. So beyond that, we know that, and I'm also going to speak to the communities that we've worked in, because this is not a monolithic experience of the opioid epidemic, but in places like the Midwest, if you want to call it the Rust Belt, we find that opioid use is frequently in the context of polydrug use, which means that it's being mixed with methamphetamine, which is big in our communities. But again, this is not a universal trend across the United States. Crack, cocaine, any given drug, these things are being mixed with prescription opioids and other types of opioids. We also know, which is a related point, is that these drugs are frequently being laced, or as they say, cut at the point of sale with other drugs to sort of change up the composition and maybe look like there's a little bit more in that batch that you got than there actually is. And a lot of times, at least to our concerns as public health people, is this mixture with fentanyl and fentanyl analogs, which is very highly associated with overdose. And oftentimes we know that when these things are mixed in, this is unknown to the user. So the level of hazard, the level of awareness, these things sort of, there's some tension between these dynamics. Other things, this is particularly in the case in our communities, but this is more of a universal trend across the United States, is that opioids, including prescription opioids, so this is not, days of the 80s and 90s where it was really just heroin. This is prescription opioids that are frequently now being injected. And this is going to contribute to risk of HIV and hepatitis C. Many of you are probably very familiar with this outbreak in Indiana, which is pretty close to our sites in rural Southern Illinois, where there was this outbreak of HIV, this largely attributable to this sharing of needles in these communities in Indiana. And then lastly, and this is going to be sort of an overlay for our conversations, that opioid use and drug injection are especially pronounced in rural communities. The other additive aspect of the opioid epidemic, which is probably the most nebulous thing that we'll talk about today, is COVID-19, this sort of sleeper that emerged over the last 1.5 years that nobody anticipated. Well, some people definitely anticipated it, but certainly not at this scale, and not thinking about the different social, economic, political, and health impacts. But what we've observed, and we do want to hedge our bets a little bit here, but we're starting to see certain trends that would indicate that COVID-19 is having an impact on the epidemic, that it is accelerating it in some way, that it's fueling it in certain ways. And we're seeing this particular, not so much in the number of people who are initiating opioid use or non-medical opioid use, but in terms of the number of overdose and in terms of the number of cases of mortality. And the reality is that many of the worst impacts are latent, which is to say we haven't seen them, or we may not see them for a while, particularly when we start to think about morbidity. So people who may have had COVID-19 and had severe consequences afterwards, just in terms of bodily consequences, what sort of medications, what sort of coping strategies that may involve medications, may they find themselves aligned to down the road, we don't really know. So just to put this in more perspective, turn to Maryland, our home site here. So in 2020, this piece in the Baltimore Sun, backing off of some research from the Maryland Opioid Operational Command Center, found that in 2020, around 2,500 people in Maryland died from opioid-related overdoses. And the vast majority, 84%, were attributable to fentanyl. I suspect also part of this was fentanyl analogs, but that wasn't mentioned in the report that I saw. And this was an increase of around 250 people. So sometimes you can look at something like 250 and say, well, there's so many people, like that's sort of nominal, but this is sort of a sentimental point, but these are people. These are people's family members. And if one of your family members or friends is in that 250, then that feels substantial. But for those of us who are more like thinking in terms of p-values and statistical analysis and regression, then it's like, well, what does this actually constitute? Is this clinically significant? And I would argue that it certainly is, and certainly is for families and communities who are dealing with those losses. Also interesting, pointed out in this report, is that the rural communities in Western Maryland and on the Eastern Shore saw the largest proportional increases year to year, which shows that there is this geographic or spatial component to what COVID has done, which has been observed on the larger scale when we look at which communities, areas in the United States have been most impacted. This is one of the first times we're starting to see these disproportionate effects with COVID, with the potential interface with opioid use, which I think is very provocative and very interesting for us in thinking about, some of these more unintended consequences or outgrowths of something like a pandemic. So some of our usual suspects for risk factors for opioid use, and this is a growing list, and this is by no means comprehensive, but I'm referring to it as the usual suspects, the things that repeatedly return when we talk about some of our quote unquote social ills. So we know history of mental illness and psychological trauma, from childhood abuse, from neglect, those adverse childhood experiences, intimate partner violence, domestic violence, social isolation. These are all things that are contributing or sort of putting people on the pathway where they may begin to use opioids in a non-medical way. Family history of substance use, poverty, being unemployed, underemployed. Consider all these things also in the context of some of our rural underserved communities, and it starts to make a little bit more sense. Working in a physically taxing job. A lot of times we hear about these deaths of despair in rural Appalachia. We hear about people working in coal mines and in the agriculture sector, developing this chronic pain, getting on the pathway to prescription painkillers, and oftentimes we know the outcome of that. We know the end of that story. Limited access to healthcare treatment, network composition, who are people affiliating with, what do people have access to, what is their influence? And then for our more recent sort of arguments here, we also have these pandemics. We have things that pop up that we don't expect, these unique ecological stressors that come up and just add an additional burden, a little bit more nuance to the traditional set of risk factors for something like opioid use. The other things that are worth mentioning when we think about opioid use is that it's not a white thing. So the typical narrative, frequently, at least you say over the last 15, 20 years, is that it's a white thing. It's a white rural thing. It's a white semi-rural thing. It's a white suburban thing. But we know, at least when it comes to prescription opioids, and this certainly varies between opioid types and routes of administration, but rates of prescription opioid use are actually pretty comparable between Black and white Americans. So we're talking about a few fractional points difference between these populations, usually hovering between like 3.5% and 5%. It's certainly not statistically significantly different. Black people, we know, and also Native Americans are more likely to die from opioid overdose than whites. And we'll talk a little bit more about why that might be in a second. Then there's also this understanding that rates of overdose vary greatly by one's geography, so where they live, and this is irrespective of race. So just think about a couple of these things here. Overdose rates are higher for rural whites versus urban and suburban whites. And they're also higher for rural Blacks versus urban and suburban Blacks. And then add in another permutation that typically rates of overdose are higher for rural whites versus for rural Blacks. So there's a lot of different permutations and computations that you can do, but what it comes down to is that these are not monolithic experiences, and people are experiencing the opioid epidemic in very different ways, based not just on their race, but based on their geography. So if we're to take all this together, we're learning a few things. We're hearing about culture, we're hearing about healthcare access, we're hearing about different socioeconomic and environmental stressors. For example, COVID-19, right? We're hearing about resources and what people have access to. And we're also hearing a little bit about how people cope just with these statistics that I just laid out. Not to mention, I mean, just to sort of add a little asterisk, that they're also contentious statistics. So how do we get here? I want to spend a little bit of time talking about the crack epidemic, and again, this segue into our more modern day contemporary epidemic with opioids. I want to talk about this in the context of reality versus perception. I think a lot of you will be very heartened by this contrast that I'm going to present. But let's step in the time machine and go back to the early 1970s, so where crack and heroin are slowly sort of inching their ways into communities in the United States, in particular, very selectively low-income communities, racial and ethnic minority communities in the United States. So importantly, like the current opioid epidemic, the crack epidemic and the heroin epidemic of the 70s and 80s, also going into the 90s, contributed to thousands of deaths, millions of different comorbidities, high rates of incarceration. This has been a big focal point when we talk about what crack did to these communities. For those of you who are more coming from that political science or economics standpoint, you may care about lost productivity, which there was a tremendous amount of. And then more fundamentally, we think about the destructions of families and neighborhoods that resulted from this. We talked a little bit earlier about risk factors for opioid use. These things become cyclical, very much in the context of families and these very close, intimate, tightly bounded networks that people have. And some of you are probably familiar with DARE. I certainly remember this going to school in the early 90s, the DARE campaign, and having the shirts and then all the good / weird stuff that came along with that. So let's talk a little bit about the politics of the crack epidemic. And again, this is all to just set a backdrop for this discussion of stigma in present day in these communities. Just a little bit about where we were and where we're at right now. So during this period, again, the 70s, 80s, arguably linked a little bit into the 90s, the political influence, the main thrust was to say, let's increase law enforcement. This makes people feel safe. Let's focus on these high volume drug using and selling communities, and let's toughen criminal prosecution. There's sort of 1 or 2 strike laws. Like this was very much codified and generated during this period of time. And notably, this was not just for dealing, this was also for usage. And also of note, this war on drugs, as it became known as, was and has been pretty bipartisan, and not universally, but by and large, there's this argument that maybe there hasn't been the active protest, but on the flip side of that, we certainly have a lack of engagement on the issues, where people are sort of throwing up their hands and saying, like, it is what it is. And we see this going from Nixon, who sort of becomes the paragon and the face of this war on drugs movement, up through Nixon. Nixon up through Reagan, Clinton, both Bushes, and Obama. Although I think Obama made some notable gains, but still the philosophy, the paradigm of this movement was very much enshrined in a lot of his work in the space. With Biden, it sort of remains to be seen. Trump, maybe one would say was a mixed bag. I think the entire legacy is a little muddled and unclear at this point. But there were different levels of reform that were attempted, not necessarily super impactful when it comes to people who are incarcerated for drug crimes, whether usage or selling. So back to this earlier slide that I had you think a little bit about. I've started to think about, and our team has started to think about these two very distinctive cultural flashpoints in the terms of like these reboots. So every 5-10 years, and with increasing and excruciating frequency, we get one of these Hollywood studios that say, hey, you remember that movie that we did in the 60s or 70s that was awesome? They're like, yeah, like, well, let's do it again. And because why not, right? So we find this. I just sort of gave you this laundry list of different programs. And if I'm looking through, I'm just like, there's a new Carrie and Karate Kid. Like, I'm not sure how you all feel about Jaden Smith. This is just not a guy who should be acting. But at any rate, there's this sort of argument, this case to be made that this is what we have. We have a bit of this social reboot of these epidemics. We have this change interface. We have this understanding that this needs to be different. There was something to this. There was some merit to what we did, but we sort of need to change how we frame it and how we present it. So keep in mind that the opioid and crack epidemic were very comparable in one way in terms of these were huge tolls on communities, on population health. The main differences come on two avenues. One is that during the crack epidemic or the heroin epidemic of the 80s and 90s and 70s, this was all about criminalization. This is looking at drug use as this fundamental existential social problem that requires one of two things. It requires incarceration or it requires some other form of punitive correction. And this has been a very dramatic shift from the medicalization of drug use, where now we say drug use is a health problem. It requires a therapeutic or medical intervention, not criminalization. If we really are earnest about changing the patterns and the trends and improving health in these populations, we have to go from one to the next. So these are very different paradigms and lines in the sand that have been drawn between these two epidemics. But at the core, we're talking about very, very, very comparable impacts on these communities. So just to sort of sum this up and give us a framework to think a little bit more about this before we talk about the research that we did, during the crack and the heroin epidemics of the 70s and 80s, the focus was on low-income people, not necessarily Black and Latino low-income people, but low-income people in general, particularly in urban areas, and then also, yes, Black and Latino people. And the whole framing, the articulation was that drug use is immoral, is deviant. These are bad seeds. These are bad people. They had this predilection towards bad things, towards drug use, towards promiscuity, et cetera, et cetera. And one of the more interesting sort of semantic maneuvers is that what's happening with drug use is that this is an evil that is being perpetrated by groups. This is not something that's happening to the group. So this is a fundamental change from what we see in 2021. And there's also these very subtle, seemingly frivolous distinctions that are made on the legal level in terms of what is a drug and what is the deservedness of drugs in terms of how we prosecute. So you look at something like crack cocaine, which at least in the 80s and 90s, and this started to change, had enormous levels of sentencings that would be tacked on if you were caught with it, whether you were using it or distributing it. And it happened to be the case that crack cocaine is something that was cheap, fairly easy to produce and sell, that it was common among Black, Latino, low-income people, versus a more posh powder cocaine, the sort of stuff that you would see like in one of these Wall Street movies with Michael Douglas or American Psycho or something along those lines, right? Something that is enjoyed by high class, upper class whites and elites. And the whole framings that come from this is that this is blameworthy, that you can do better and that you should do better. And that brings along with it a ton of stigma, which we're going to talk about later. So the shift to now is that now we start to look at this in terms of the plight of higher income and white people who use opioids. So now we look at it as a very intuitive thing. This is intuitive. This is understandable. Of course, people are falling on hard times. They just lost their jobs in the coal mine or the agriculture sector. This business just shut down. Like the main street in this community is in disrepair. Of course, people are going to turn to these sorts of alternatives, while ignoring that these same sort of social, economic, environmental stressors very much existed in these communities in the 70s and 80s. There's also this idea of influence, that people are just falling in with the wrong crowds, and this is why they were influenced. And then on another level, again, I talked a little bit about these individual subtleties that are associated with, we're making very calculated decisions about what is okay and what is not okay drug use is. But in the case of the opioid epidemic, now it's like, anything goes, because these are systems and structures. So one thing that I really emphasize in my class a lot is that like we have to unpack what that means. Like systems and structures aren't really actual tangible things. Like when you say that, you're talking about the government. Okay, we're talking about institutions. What is an institution? Are we talking about hospitals? Who at a hospital? Like surely it's not everybody, but what's happened is that there's a whole mystique now around systems and structures where you can just say that this is a systemic issue, this is a structural issue, but not really, articulating what exactly that means. It doesn't really give us a target. But because we have sort of this cloak now that it's easy to say it's institutional forces that are related to the opioid epidemic. It's the bad medicine. It's these corrupt, no good clinics. It's big pharma, right? It's Johnson and Johnson. It's these other big players. It's deindustrialization. It's in the community, which means there's really no fault for this. There's no one to blame. And that makes things a lot less destigmatizing because this is no longer about the individual. This is about the boogeyman, right? This is about the person behind the sheet, the wizard in the Wizard of Oz, right? These are untouchable people because we say so. So let's think a little bit more about some of these shifting tones in recent decades on drug use and opioid use. So I found a few articles that were posted. I'm going to give this to you generational, so early 2000s, early 2010s, and then closer to where they're at right now. So pay attention to some of the trends, the language, the utter shock and the surprising sort of verbiage that is employed. And I'm not going to read all the quotes, but just to give you a little bit of flavor. So the first one in the Denver Post in 2001, which is fairly early in our understanding of this epidemic. So this is a person who's saying this isn't about inner cities and successive generations of unemployed addicts. This is about suburbia, rural America, Amish country, for heaven's sakes, middle-class high school students who have seen their lives unexpectedly derailed. So there's this level of surprise. This is saying like, this isn't what we expect. This is like, yeah, we would get that if it was in inner cities. This is happening in places where we would never expect it. This shouldn't happen to us. There's this expectation that this would never happen to us. And this sort of language carried on through much of the literature and the news media that we read in subsequent years. So this gets a little bit more personal to the point when we think about what is the image of a drug user. So this person's saying in the Roanoke Times in 2011, I'm not talking about homeless bum looking street people who use drugs. I'm talking about the relatively affluent, well-dressed, people driving Volvo, kids who belong to honor societies, who are playing soccer and lacrosse, who are headed to good schools. Again, this shock that this could possibly happen to this community with a complete lack of nuance and understanding, like, well, this ideally wouldn't happen to anybody, but we certainly wouldn't expect it to happen to this particular population. And then lastly, in this Connecticut Monitor, a younger person saying, right in an op-ed, my friends and I have watched our peers drop like flies over the past few years. It's only getting worse as the nation's opioid crisis intensifies. You might have imagined I'm from a rural area or an urban neighborhood, but these are suburban upper middle class kids you would never thought would go down that path. So this is really a little bit of like this cognitive dissonance of what is the expectation, understanding of who gets into this world. Clearly the articulations here that like we wouldn't expect it with these populations, but everybody else that I just mentioned, the lower income people, these people are coming from, as you might say, disenfranchised or underserved communities, that this is sort of expected to a certain extent, at least by the population of people who are looking down and writing these articles and saying, this makes sense for you, this doesn't really make sense for our people. So what comes along with this shift in this narrative, this understanding, this collectivist attitude, and this is a really big point of like, it can happen to anybody. In the 70s and 80s, it was like, no, this will happen to you if you're living a promiscuous life, if you go to certain sort of clubs, if you party a certain way, if you're just black or white, if you're lower income, if you live in quote unquote slums or ghettos, it's going to happen. With this collectivist approach, it says that it can happen to anybody, whether you're that Fortune 500 CEO, the father of two, the mother who's working a 9 to 5 in a low density community, not making much money. This can happen to anybody. So this is a very different shift. And also importantly, when we think about what are these sort of cascading effects, is that we also have this shift in saying this is also correctable. Where with the crack and heroin epidemics, that was not necessarily, sort of the silver lining. It was much like, well, we're going to throw you in jail and maybe this will fall out of you. Like you'll just, de-drug yourself, for lack of a better way to put it, without actually us having an interface to it. But to the point of policing and over policing, which we alluded to a little bit earlier, the argument has been in this new area that we can do all these things without having this extreme policing and without having this draconian system for judicial sentencing. So what has this led to? This has led to more favor in the public for things like clean needle exchange sites. This has been an emergence in Arizona, for example. And not that Arizona didn't already have clean needle exchanges, but sort of operating under the radar. But now the government's saying, we get it. Okay, we get it. This is something that we need. One of the more novel things many of you are probably familiar with is these safe consumption sites that we're starting to see, particularly in New England, which we'd expect, and the Northeast. But we're starting to see these dramatic shifts in tone and culture and acceptability. The Supreme Court and other lower courts, these federal circuit courts, considering now they there's something not quite right about saying that these are two drugs that have maybe comparable impacts, and the sentences for using this drugs are dramatically different than person, using Percocets or benzos or whatever the case may be. And then we also have drug courts were a little bit more contentious, but nevertheless, it's a recognition from policy stakeholders saying that we need different approaches for these people because we don't want to throw them in jail. We don't want them to die. And this was not the language and the tone and sentiment that characterized the 80s and the 90s in relation to the crack epidemic. So in spite of these shifts, which feel very promising and affirming, we know that stigma and discrimination against people who use drugs and drug use in general are very high in urban, rural, and suburban communities. So what's behind this? So let's think a little bit about these evolving perspectives and why they matter. So first, and I don't want to make this a whole conversation about media and make media the scapegoat, but the depictions that we get from the media are very potent. If you look at any given Pew poll, we know consistently that media is a huge driver of our social attitudes on what happens and why it happens. So it matters. And we know by virtue of this that social attitudes directly impact policy. And why? Because politicians care about what the public thinks, at least up to a certain point, and they formulate their policies as a process of policy feedback in correspondence with that. And it also creates this really interesting debate around deservedness. I promise you this is a word, deservedness, about who deserves social support, who deserves medical resources, who deserves leniencies. It's really starting to amplify and create this very kinetic debate about what people deserve. And this is an ongoing thing that's not just restricted to drug use. It's also a conversation about something like social welfare and public assistance, and just in general, how much am I obligated to pay for things that you need when I think that you don't really deserve it? I'm not like you. I don't have those troubles. So why am I part of financing and bankrolling your issues and trying to provide for you? But the flip part of that is that if we have more public empathy, if we can make the right message, then these outcomes among these populations, which are quite dire and worsening, we believe in the context of COVID-19, then we could create this empathy and we can also improve these different outcomes. And we can also, on the flip side of that, and these things are very much related, we could decrease these very unethical, immoral, and quite irrational, and also counterproductive imprisonment and sentencing regulations that we're seeing in relation to drug use, which again had this bent towards lower income, rural, and racial and ethnic minority populations. So what is stigma? So stigma is this concept that was developed by Erving Goffman, a sociologist, in around 1963, who wrote under this context of a spoiled identity. So the gist and the framework for stigma for Goffman is that it's referring to this specific attribute in a person. This runs a gamut. This can be your body size. It can be how you speak. It can be you having a tattoo. It can be you having that, otherwise very cool nose ring, right? It's a behavior. It's you using drug use. It's sexual sex intimacy. It's any given level thing that you do, but it's all socially constructed. It's people as a collective saying that we're not okay with this particular thing. And it's also associated with your social position, being an ex-con. These are all things that put you outside of a certain expected, affirmed norm of what you should be. That again is going to have these dramatic downstream impacts. So consider a few things. Stigma is very adaptable. It's very fluid. It changes over time, again, with the shifts, the momentums, the winds of our cultures and our countercultures. So something like HIV, which has been very, very much stigmatized over the last, 40 or so years, it still exists, although HIV itself has very much entered a new phase in terms of, if you want to call it its half-life, in terms of our ability to management, to put it in clearer terms, has dramatically changed with things like PrEP, for example, right? So it's not that death sentence, but the stigma around it of having it is still very much there. And how do you change that? We're going to talk a little bit about that earlier as we start to bring all this into full circle. I'm not going to go through all of these, but these are some of the more humorous or interesting ones that I found. So there was, and please don't spend a lot of time on Reddit because it'll just leave you feeling empty and hollow at the end of the day. But I found this on Reddit. Why is there such a bad stigma about being rich? Yet everybody wants to be rich. I just got a few of the quotes, one person, one word responses, which of course, that's what you're going to get on Reddit, right? Envy, jealousy, because those who aren't rich constantly blame the rich for keeping them down. Is it possible to be stigmatized because you're rich? I think there is. I think if we're attempting to be culturally competent or culturally sensitive, then you probably have to adopt that paradigm. But this is also the point. Things that we wouldn't necessarily think are things you can be stigmatized for, they certainly can be, and they are. They are just by virtue of people feeling that. Stigma related to obesity, long-running literature related to stigma against LGBTQ and the downstream impacts on their ability to have a high quality of life, to be able to get jobs, in addition to just how do they integrate and feel a sense of belongingness in their communities. Other things, veganism, which I didn't know that existed, but these are very salient, important things that we have to be mindful of. And it really just runs the entire gamut. And also you have ones that are a little bit more intersectional. So consider something like schizophrenia, consider comorbid conditions, consider being homeless, and then to our point, consider addictions. These things are all related. This is referred to traditionally as sort of like an intersectional or interrelational sort of trauma and stigma. And that's not adding on the additive effects of race and ethnicity and a person's religion and their gender. These things amplify and augment this experience of trauma. So in our particular context, why do we care about stigma against opioid use? Because one, we know that it's associated very tightly with depression, with people feeling isolated, with lower healthcare utilization. And we also know to a certain extent, the literature isn't super robust on this, but we know in general that people who feel stigmatized, who have that internalized stigma, are more likely to engage in, if you'll say, riskier or more hazardous forms of opioid use and drug injection. We also know, and this is sort of tangential, but it's all related. These are things that are all really in a cycle, is that stigma has a direct impact on access to employment, of getting a job, right? There's that employer bias because they're picking up on those cues, those attributes that we just talked about. Like this person has a face tattoo. They seem a little jittery, like the jittery. They're not speaking the way that I would expect them to. And there's a whole level of assumptions about that person, that they're not going to be reliable, that they're not going to be professional. And we see this across a whole milieu of education, housing, et cetera, et cetera. So this is going to have impacts on people's quality of life, on their ability to attain opportunities, and it also has an impact on life expectancy. These are very real, codified, evidence-based relationships that we're seeing. So what does stigma even look at? And this is really important. I'm sure many of you could point out many other examples of these things, but consider it like this. Like if you step back for a moment here and you think about any given thing that you stigmatized before, we've all done it. It's uncomfortable to think about it, but we all do it to a certain extent. So consider this in the context of a person who uses opioids. And some of these ideas come from actual data that we had from people who use drugs who are in our project. So we say to them, like, what does stigma feel like to you? What does it look like? And they say it's in our, and I'm going to say our as a general public, which I don't really like that framing, but humor me here. So it's in our body language and our behavior. So it's avoiding someone who seems like they lose drugs. Because again, it's these stereotypes. They maybe have the slow speech. Maybe they've got, the tattoos. They look disheveled. They look, or they smell in some way, right? Like some of these tropes that are associated with a person who just doesn't have their stuff together, right? Giving those certain looks, maybe not even looking at them at all. Like that's also very potent. The dirty looks, talking down to them, Sorry, that's a typo there. These are other things that sort of crystallize a person's experience of like, this is how people feel about me. It's also very much in our belief systems. And look at people who use drugs are immoral, they're weak, they don't have self-control. They could quit if they wanted to, but they just don't want to. They just don't have that internal fire, that desire, that passion to be better because they just don't care. It doesn't matter to them. But we know that's not the case. That these people have the same ambitions and goals as anybody else, but they have many other barriers and complications to reaching some of those goals. The other things that start to feel a little bit more insidious are the extrapolations to say, if you use drugs, that you're prone to these other things that are unsavory, that you're gonna rob me. Like if I'll leave you in my home for this amount of time, like half of my jewelry is going to be gone or the silverware is going to be missing, right? That you're going to be violent, that you're going to engage in promiscuous activities. It's also very much woven and embedded and ensconced in our policy. Over policing, the targeting, harassing of people who are just suspected of people who use drugs, right? And we've seen this play out very much on the national stage when we think about recent racial justice protests. They're very suspicious. The whole stop and frisk sort of paradigm is built around this idea that like, if you look like it, then that's enough of a basis and justification for us to explore this a little bit more in ways that feel super stigmatizing and disenfranchising for people who, one, may not be engaged or have drugs or paraphernalia on them, but also sort of just a general violation of their space, this assumption about who they are just by virtue of who they are. We also see this in the punitive sentencing in courts, which we talked about a little bit before. We also know there's this very clean intersection between politicians and court, right? There's a lot of back and forth there. That is a collaboration and relationship that is sort of hard to distill down. And we also know that there's general regulations in these communities, the limited support for harm reduction, saying like, there's no way in hell you're putting a safe consumption site in our community. It's just not going to happen. Even something like medication assisted treatment, where a lot of people say like, you're either clean or you're not. If you're on, methadone, then you are not clean. You're doing something good for you, round of applause. But this is also still sort of replacing one opioid or one drug with another. So these attitudes persist in these communities, which leads to this regulation, over-regulation of resources that will otherwise be very beneficial to these socially medically vulnerable populations. So now on to our project. So the Delta Rural Health Study is a project that we implemented in 2017. I should note this is when I was affiliated with the University of Chicago, who I still work with, and also Southern Illinois University. So this project was a multi-year study that was funded by NIDA under the NIH to just sort of generally explore what are the lives, health of rural people who use drugs. So other states that were funded, some of you who are actually on this call may be on those projects or are familiar with them, but the NIH funded around 10 sites, and just highlighting a few here: Kentucky, West Virginia, Ohio, North Carolina, also New England, to say we want to look at the same things, like what is the epidemiology of this? What are the spatial dynamics of this? Where are clusters? Where are hotspots? What is happening? So we use surveys and interviews to understand what are these risk factors in terms of culture, in terms of family dynamics, and some of these spatial and environmental dynamics. What is contributing to this? We're also very much interested in social support networks, sexual networks, to know where are people getting their support at? Where is the risk potentially coming from in these relationships? We're also very much interested in needle usage and sharing, although we didn't find that this was very escalated or elevated in our populations of people. And then for the purpose of the research that I'm going to present, we are really interested in stigma, social isolation, and discrimination. And also, just as a tangential thing, I'm not going to present all this, we also were collecting biological samples to test for STIs, particularly emphasis on HIV, and also looking at hepatitis C. And for the most part, these rates were relatively low in comparison to certainly an urban area, and definitely in comparison to other rural communities. So these turned out, fortunately, not to be big areas of concern for us. So a little bit more about Southern Illinois. I'm sorry that I can't really show you my cursor. You may be able to see this, but if you look toward the middle of the screen, you see Illinois next to Indiana, Kentucky, Missouri. Look at this orange dot. This is roughly, in a very crude way, rural Southern Illinois. So this is around 16 counties that border Missouri to the west, border Indiana to the northeast, and Kentucky to the southeast. And keep in mind, these are also very high drug traffic areas. So you look at this as like almost this is potentially a pressure cooker, right, of potential outgrowths of overdose and morbidity. And to some extent, it's actually been that case. And also mentioned to you the famous case of Scott, Indiana, and the big outgrowth of these HIV cases. This is not far from that community, but fortunately, to a certain extent, there's been this sort of buffering effect between what happened in Indiana and what happened in Illinois. But sure enough, there are communications between these places and people who use drugs in those different states. So other things, there's one syringe service program serving this part of the state, and this is a third of the state, maybe closer to a quarter, but somewhere in that range. So you have one mobile unit, one person essentially, 2 or 3 persons team who we collaborated with, who is serving this monumental, enormous geography, which is given the need, what I've just articulated, like this is a hotspot as defined by the NIH and the CDC, and we have one syringe service program there. And this syringe service program, provided, condoms and contraceptives and PrEP, sterile syringes, et cetera, but it's one operation for a population that has a vast, great need. So actually for the second part of our study, we're trying to find ways to implement more of these services. So a little bit more backdrop about Southern Illinois before we move on is that this is a low income and limited resource community. So Southern Illinois has had this steep and steady and ongoing deindustrialization attributed to its coal mining industries and also to a lesser extent its agriculture industry. And what comes with this? Population loss. When jobs go away, people move. Frankly, I'm actually located in Chicago right now. A lot of people are coming up to Central Illinois into some of our communities in Chicago. So this is the Orient 1 coal mine in Franklin County, Illinois. So this is one of those 16 Southern Illinois counties that I talked about earlier in 1915. And I believe this officially closed, although you could say it was defunct well before that in the early 2000s. But this was the essence. This was the bread and butter for these communities. This gave these communities economic base to build from. It gave them a tax base or base to build from. Also gave these people in many ways an identity. It gave them something to feel bonded to. And these are things that are really totally extricated from these communities in 2021. So on to our study, examining opioid and drug injection stigma in some of these rural communities in Southern Illinois, focusing on professional stakeholders and their views on what this whole thing and this experience is. So for this study, we conducted confidential interviews with various I'll emphasize professional stakeholders who work in rural Southern Illinois. So we ended up speaking with 30, and this was treatment providers. This was actually also some harm reduction providers, one from this one clinic that we work with, law enforcement officials and officers, court officials, primary care and ER physicians, EMS workers, and we also spoke with maybe around 4 or 5 people who represented faith-based organizations. So why do we focus on these? These are the populations that regularly work with, interface with people who use drugs. So they're very central in the lives of these people, for better or worse, right? But they also have these very applied and nuanced insights into the broader lives and experiences and the needs of people who use drugs. Also very importantly, and this is, I think, a very important point, is that they have a certain level of discretion. So you have, as we do throughout this country, very fragmented, very diffuse systems and social services and your Department of Health and Human Services or Child Welfare. There's a certain level of siloing and fragmentation that exists. So when that happens, you tend to have a lot of the big decisions that are made in individual cases by people who may not be suited or even comfortable making these big decisions, but nevertheless, this is what happens. So Michael Lipsky, who's a political scientist, came up with this idea of street level bureaucracy, which basically says you take people who work for organizations in the government, in healthcare institutions, and the big wigs say, do this, right? And then the person gets this policy, they're charged with implementing the policy, and then the turnaround from that is just like, I don't really know what to do with this. Like, this actually doesn't make sense in application. So what happens is that they start to use their discretion for better, sometimes for worse. And what I'm going to demonstrate to you in the slides that I present in the last few that I have here is that oftentimes it's to the worst. But they also importantly have a tremendous amount of impact and influence on the health and quality of life of this population. So the interview questions that we had asked were focused on understanding, how do you understand opioid use and drug injection? How do you feel about it? Why do people do it? Why did they initiate? Why did they decide to continue? How do you feel about harm reduction? What do you think about syringe exchanges and syringe services programs? What do you think about naloxone and using it? One thing that I noted in Southern Illinois is that through this Heroin Crisis Act that came into law, I believe in 2017 or 2018, first responders became legally obligated to carry around naloxone, which was quite controversial at the time, although I think some of the rawness around that has started to settle. Other notes to keep in mind as I present this data is that the communities were predominantly white. 90% is probably a fair estimate, maybe a little bit light, probably more around like 93, 94%, and all but 3 of the 30 people that we spoke with were white. And this was not an intentional act. We didn't go out looking for it, but when we looked for the key stakeholders, who are the movers and shakers, who are the people who are doing this really seminal work, this tended to be white people in this community. And for our purposes, it doesn't matter a ton because, again, these are also very white communities in terms of the general population. Other quick notes in terms of our methods. All the interviews were done by one of our research staff members who are trained in qualitative interviews, and they generally lasted around 1 hour. We audio recorded them confidentially, and then we analyzed the transcripts that emerged for some of these common themes. So what emerged out of this, and we've had a couple of projects for this study from our Illinois site, was this project that, our paper that we published in Social Science and Medicine, I believe late 2020, where we're looking at stigma, and we're trying to understand how do professionals understand opioid use, drug injection, treatment, overdose prevention in their rural communities. And we found a lot of really interesting things. So just to give you the broad landscape, in general, most stakeholders held stigmatizing views. And I sort of want to couch that and put a pin in it to say, there's some subjectivity to this. So what am I relying on? I'm relying a little bit on the language, which is very contentious. And I'd actually be super curious to hear from people like, the movement has been like, you don't say addict anymore. You don't talk about addiction. SAMHSA's actively having this conversation. We don't talk about abuse. So there's this shift. There's a shift in the zeitgeist in terms of what we can or can't say. So one of the funny things for me is somebody who adopts in this field 4 or 5 years ago, who would say like, okay, what language do we use? And you get sort of an old timer who says like, I can call myself an addict. Like, you can call me that. I don't care. And I say that this is sort of a superficial point. I don't want this to obscure from part of the larger conversation. But when I talk about fluidity and adaptability, we don't know what all the touch points are, the levels of sensitivity for how we even articulate what stigma is and what is stigmatized. So these stigmatizing views, if you want to adopt that at this point and say stigmatizing, they were sort of refracted in a few different ways and kinds of beliefs that show these very deep chasms in terms of relatability and empathy. So these ideas that we hear from our research participants, stakeholders, again, healthcare providers, physicians, social services workers, some government officials, people working in courts, is that people who grow up in criminal, chaotic, unethical families, they were inherently bad seeds. So yeah, the apple doesn't fall far from the tree. Of course, they were going to use drugs, right? There's this understanding that like, yeah, this is going to happen. Like, it's fairly logical. Although there is a bit of animus that's built into that. This is not framed in this lovey-dovey way. This is like, yeah, we get why like that's not okay that this happens to be the case, but we know it's the case. This idea that people who use drugs have no goals or ambitions. This is totally not strength-based, right? It's saying that like they really are one and two things before and after drug use. So again, of course, this is the track that they're going to fall down. And there's also this question of abstinence, which, as we know, when it comes to harm reduction, abstinence is typically not the end goal. It may be a very tangential goal, but generally it's not. So what happens is that we have a lot of participants who say people are just too weak. They don't have the willpower to quit. They could, or they just don't want to, because again, they have no goals or ambitions, right? Or because they grew up in these chaotic families, they have these negative influences, they just don't want to do it. And we know logically, intuitively, that this really doesn't make sense, but these are very prominent perspectives from people that we spoke to. The other really big thing, and this is sort of the professional interface, is people believing that people who use drugs are a drain on society and taxing to the work that these professionals are doing. What does this sound like? It sounds very much like arguments that we heard about people on welfare in the 80s and 90s, that these people are a drain and suck on society. We also hear this sort of verbiage adopted when we talk about immigrant and undocumented populations, where we say these people are a drain on the society. We have to provide too many services. We have to do cultural competence. We have to, convert documents, right? Like there's so much work that we have to do, which is going to deny the baseline humanities of the populations. However you feel about it, I think we can agree on that sort of point. What you do in response, we're going to talk a little bit about that a little bit later. Okay. So we're just about done here. I'm going to run through some quotes and then we can try to wrap up. So this person, a sheriff in our sample, saying, I look down on people who use drugs. I wish I didn't. I try not to. I try to be a good Christian. I try to be an empathetic individual. It's just exhausting and draining. And a lot of times I don't feel like what we're doing is worth it. Like this is a pretty damning commentary. And he turns this a little bit deeper into like, here's how it should be. To me, it's just simple. Quit doing drugs, clean up your act, get a job, use that job to better your education, use that education to better your job. So I have to say there's some very lyrical and poetical about this that I like, but like communicating this to a person who uses drugs is like, okay, like what's the end road for me to start this? And what if that's just not what I want to do? What if that doesn't affirm me? Like that consideration is not there. And we don't necessarily expect this level of nuance for somebody who's working in these communities, who's not germane to some of these broader conversations and arguments about who these people are, what they want, what they need, and what they feel like they're capable of. But we can build capacity. Okay, so another interesting point came from this treatment provider who says, clients who go to the doctor's office who have an opioid use history, those people are more likely to be seen as non-compliant. Many of you are probably very familiar with this. If you're clinicians, you see a certain person, you make a certain assumption, which is difficult to not do. And your immediate thought is like, they're not going to follow my recommendations anyway. I'm not going to dump an hour into time and to try to sell this person on this treatment or make this referral when I know they're not going to do it because they didn't do it the last 10 times. But the downfall of this is this thinking that they're not going to follow through. They're not going to take their medication, which is deprivation for healthcare. There's no really other way to put it. But this person is acknowledging, so I think that they're stigmatized, people who use drugs, and I think because of that, they receive less good care. So a physician sort of really accentuates this argument and telling us one of the most frustrating things can be when the patients paint a picture. So I'll admit this language was a little sticky and took some time to get through, but once I did, I was like, oh, I get it, and this feels a bit potent. So he says, one of the most frustrating things can be when the patients paint a picture before you go in and you say, this is our drug user. What he's essentially saying here is that like, even before I've seen the person, like I'm hearing things from the attendant or a nurse, right, who's saying like, we've got somebody, they're a little belligerent, and already before I've met this patient, I know what they're about, and I know what comes with a drug seeker. So he says, sometimes I'd rather not know until afterwards, but this practically usually isn't possible. And he says very flatly, you can't trust them anymore if you think that they're a drug seeker. So when you get, patients, people use drugs who say like, I don't feel trusted, like, this is it in spades. This is a person saying, once I've sort of identified you as a stereotype, then I'm going to act accordingly. I'm not going to trust you. And that is a clear fissure and erosion of that relationship. So sterile equipment, slippery slopes. I'm going to finish up here, hopefully in the next 5 minutes. I hope people are okay on time. If I'm being intellectually honest, a court official says, there's something that is just a little repugnant about saying, here, let me help you with that. But he's also going back to say it sure makes sense to have clean needles. So he's sort of like tortured by this logic, this practical side of him versus this more like emotional or sentimental side of him. And he says something repugnant about saying, here, let me help you out with that, isn't saying, let me give you these clean needles. Let me help you do that really bad thing that you're doing a little bit safer. It's a slippery slope. Why are we encouraging people to do this thing they shouldn't do? So this is also very much sort of an artifact and an extension of what we're seeing across this country. El Paso County Health Board. This is all in the last few years. Holt's needle exchange plan. Columns in a Cincinnati periodical, needle exchange is a bad idea. Needle exchanges save lives, infuriate neighbors. Now they face budget cuts at the edge of Portland. Chris Christie, fairly early into, I guess, towards the end of his tenure, though, had vetoed this expansion of needle exchanges in New Jersey. Huge backlash. This ended up not happening. And then in Tallahassee, we have a person saying that flat out needle exchange programs are not the right options for us. So it's very much wedded into our media, and it, as a result, sort of absorbs and sort of calcifies in our public conscious and in terms of how we relate to what's happening. So one of the most interesting things, and one of the reasons why I'm here, I got a little bit of a selling point, right? I mean, I'd love to hear feedback on it, is that in contrast to some of the other research that we read, and this is something that also feels intuitive once we arrived at it, we start to see like, wow, everybody's saying this, is that stakeholders were most often concerned about the financial rather than the social, moral, community aspects of opioid use. So oftentimes they're thinking very explicitly about like, we're spending taxpayer money on this. We've got community priorities. The park shut down right now. Like, we want to open up the community pool. We want to have community events. And my money is going towards creating a safe consumption site. I don't know anybody who uses a safe consumption site. I don't understand this. Like, why are we doing this? And again, it tracks back onto this idea of deservingness. Not just what does this person who used drugs deserve, but what do I deserve? What is fair? So we have this health department official who says, my mother, for instance, she's a diabetic, she can't get free syringes, which actually is not the case. So this is not the case, at least in these communities, that you can't get free syringes. It's not just relegated to people who have substance use or opioid use disorders. If you are diabetic, you can actually get free needles. She doesn't know this. For somebody in health department capacity, that's a little concerning to not know this, because oftentimes they're sort of brokering, these pathways and policies. But she says, but the drug addict down the street can, and they can get free Narcan. Why are they getting free stuff when I have a condition? I need the exact same thing. It's not really fair. I don't think it's ethical. I don't think it's fair, but I understand why they're trying to do it. So this becomes a really interesting anchor point for us as we think about the socioeconomic and class dimensions of this work. Another guy who's sort of tracking onto the same language, who says, I'm pretty conservative in my politics. We didn't solicit his politics, but he told us, I'm not about giving everything away, right? So this is very traditional small government sort of ethos. But the reality is that addicts, to get clean, have to have these interventions, and they're not going to be able to pay for it, most of them. So would I be willing to as a taxpayer, to participate? I would, yeah. Would I be open or okay with some of my tax dollars going to fund these clinics? I would. But this is also a treatment provider who's very much in this space. So this doesn't necessarily seem like such a cavalier remark, but it's nevertheless a notable one, because it's one of the few in our study who actually said, like, this contrasts with my political beliefs, my ideology, but I get it. Like, I understand the science makes sense. I've seen the outcomes. I get it, but that creates some uneasiness in me. It makes me a little nauseous to think about that. Another quote, I would say that the community's perception is that people don't deserve to receive Narcan, that they deserve to die. It's a little bit of this like survival of the fittest mentality. I see it played out on social media. Anytime there is a post about that kind of thing from a local news source, and especially if they know that the Narcan is coming from grant money, they don't believe that their tax money should be used to save people who, in their eyes, are not worth saving. Mind you, that this is probably a very nominal amount of their tax dollars that are going to this. And at least in a place like Illinois, a place like Chicago fronts a large amount of sort of this municipal debt in these communities. So this is a reality. So wrapping up here, so implications. Stigma against opioid use goes beyond concerns about the act of using drugs. Like, these are interwoven. You can't have a conversation about stigma and say like, well, they actually don't care that people are doing this thing. They do care, but it's also shaped about these more intensive thoughts about what is your capacity and what is your willpower. Because if you don't have the capacity, you don't have the willpower, what does that say about me? Why can't you be like me? There's a lot of that. There's also these local politics. Again, politicians reply to media, right? Like, I mean, if you turn on Fox News right now, MSNBC, CNN, give it 20 minutes and you're going to see a politician on there hawking some program of theirs. And give it a couple of days and you're going to find one who's on there talking about the opioid epidemic and here's what we need to do, blah, blah, blah. It's salient. We talk about the opioid epidemic because people care. Politicians talk about it because they know that these are issues, that these are ravaging communities. Otherwise, feeling burdened professionally. These disconnects, I think this is particularly potent, these disconnects in shared identity and expectations. So keep in mind, this is white stakeholders talking about a white community. This is not the racialization that we're necessarily seeing in other communities, certainly during the 80s and the 90s. This is white stakeholders who are talking about white residents who in a lot of ways share similar socioeconomic traits. So in some ways that's pretty profound. In terms of the racialization of the drug war and drug use, we're not necessarily seeing this, but also it happens to be the case that, 7-8% of the rural Southern Illinois population is Black or Latino, right? So there's not a lot of us out there. But the bigger take-home point here is that there's a lot of awareness of what it takes to improve the health, the well-being, the stability, the feeling of being embedded in a community among people who use drugs. Stakeholders are aware of this, but they can still be vehemently opposed to actions and procedures to address this. So there's this taxpayer burden. People who use drugs are a logical scapegoat where populist and these NIMBYist, not in my backyard sentiments are high, which is very much the case in rural communities. Because of what they do, of what they look like, of them being a nuisance. If you want to pick one of these other stigmatized populations, it's not like one of these things where you go into a community center and you see somebody who appears to be high, who's stumbling around, like it's very visible, it's very much in their lives. You can't really look away from it. So these become a very logical scapegoat for this whole sort of populist movement around like, what are we doing with our money? Why are we helping people who don't deserve it? The other aspect of this is that rural residents place a big emphasis on government funds. But why do they do this? Is this just, again, like this small government fetish that people have? Or is it like we're in competition for these limited resources in our communities? I don't care if the government wants to give $100 to help support this Narcan initiative. I think that could go towards something else. But you can't divorce that from the reality that they also just don't like drug use. They don't like drug users. So I don't want to obscure this and say like it's just a money thing, but money is a part of it. So you can take some of these sort of sassy quotes, and as qualitative researchers, we go through transcripts, we look for the themes and the commentary that really reflect what we're looking at. So a lot of what you see here, these are like some of the more provocative ones that just express like, this person is really serious about this. They really feel this strongly. So this is not people being sassy, having one-liners. These are people saying like, we care about these things, but we also care about the bottom line. So again, this is not a rebuke of drug use and opioid use and how you're doing these things. It's looking at government expenditures in communities where there's not a lot of allocations for basic services to maintain roads, to maintain schools, to have recreational experiences for families and individuals. So this sort of boils down to stigma being this cudgel that people use to preserve this identity. So our anti-stigma efforts, especially in rural areas, have to focus on the concerns of the communities. And frankly, I mean, this feels a little gross to say, but oftentimes it's not the public health angle. And I think we could spend more time creating a very nuanced and rich explanation for why we should care about, in the case of Maryland, right, that we lost 2,500 people to opioid related deaths. Like that on its face feels very compelling and provocative, but it doesn't appear to be moving the needle at the scope and scale that we would want it to be doing that. So cost effectiveness may be the most ideal focal point. And again, this feels a little gross and slimy because it's just like, is this all just about money? Like we're just going to go now and say like, get on board with harm reduction because it's going to save you a few bucks on the other end of this. Like, no, we want to make the humanistic argument, but we have to know who we're speaking to. And in these communities, going with the argument and the narratives about this is what people are going through and this is why we support it, is not going to be as much of a selling point. And mind you, this is provisional research that we're beginning to do, we're starting to find is not going to be as effective as a cost effectiveness approach. And we also know we have to message it. We have to say that this is saving taxpayer money, it's saving lives in the long run, and it's not this big burden and this sort of poisoning of our communities. This is going to make our communities better in the long run. And we also believe, for those of you who do work in social media, we're starting to make some entries there, is that this is going to be, in my mind, this is the frontier. This is the next frontier for anti-stigma campaigns, because people are having these conversations. Politicians are reading these conversations, and they know that this is sort of the melting pot where these conversations about what should I do and what should I not do as somebody who's delegating and managing and curating policies in these communities. But more generally, we're talking about improving these structural conditions. So this is the one that feels a little bit more nebulous, because like, okay, well, Drew, we don't have, the $500 million stimulus to start propping up, strip malls and fresh grocers and improve all these roads and improve our schools and attract and retain, healthcare providers who want to work here, who will work here, and educators who want to work here and will work here. But this is also the reality. Like if we're addressing these underlying things, economic development, investing in education systems. With the last stimulus has allocated some funds for this. How's that going to play out in rural communities? We don't know. But this is going to be our clearest path of resistance, least passive resistance, to improve outcomes in these populations. Also from the standpoint of not just people who use drugs, but also in terms of starting to stem and eliminate some of these negative public sentiments. So just a couple more slides here that I'll end with is that the idea of educating people is often like this panacea and solution to bias and discrimination, bigotry, et cetera, right? Like if you wouldn't be transphobic, if you just knew X, Y, and Z, if you didn't just read this book about, like how gender works, doing gender, undoing gender, you would feel differently, right? Like you would feel differently about like this Latino person if you just spent some time around them. If you read this book, if I'm saying this, very facetiously, like watch some Lin-Manuel Miranda, right? And you're going to feel very differently about this population. We know like this is really not the truth. And what's I think most salient here is it's the level of awareness. So this does not mean that everybody in our study or these populations can go out and write a book about stigma, and I arguably can't do that either, right? I would love to, but like there's a lot of stuff going on with stigma. There's more that we need to investigate to really couch this in a way where it's going to be substantive. But people are aware of what's going on in these communities. They know that people who use drugs are underemployed. They know that they have these medical comorbidities. They know addiction, at least in some sort of maybe albeit distant way or distal way, that this is very challenging to have what they refer to as an addiction, right? They know about Narcan, like they've watched, somebody probably seen Pulp Fiction. I don't really know if that was Narcan, but there's a scene where John Travolta, as we'll say, injects life back into Uma Thurman, the character in the show after she has this overdose. Very dramatic as a Quentin Tarantino movie would be, but people sort of know in general what these things are about. They know what needle exchanges are. They know about syringe services. They may not know them in great depth, but they know what they are. They know what the purposes are. And you can know that, and you can still not care about amplifying these resources in these communities. So education, which sounds strange to say for somebody in the education world, but is not strictly speaking or per se the answer. So people are aware of what they know. They're also aware of their biases. They're self-aware in that regard, and they know the roots of these biases. They know these come from their communities. They know they come from their families. They know they come from politicians that they may like, right? So it's important to have people recognize these biases and also the contradictions that exist in there as we shift between these practical concerns. We want harm reduction because we know it's going to eliminate X, Y, and Z, and we know people aren't going to stop using drugs. That this is a fallacy. This is a dream that we're going to reach that point, as noble as that could be to a certain type of public health advocate, right? Versus the more humanistic points is like we want to improve the quality of life of these populations. So how do we find that middle ground? These are questions I believe for all of us as we start to tackle these questions more and more. So again, other things that I'll add here, these have a tint of sarcasm in them, but education, again, particularly when it's viewed as virtue signaling, people aren't familiar with that. These are your social media influencers going on and telling us to be happy during the pandemic and, to look on the bright side and, to do this and that, right? This is the essence of that. So these things are not likely to change people's core beliefs and action. We know this from research, and we know this also from the huge backlash that their tweets and that their YouTube videos get. But we also know on the flip side of this is that the sympathetic portrayals, creating the relatability. Everybody that we spoke to in this study has this relatability gap through and through. But we also, again, want to emphasize that like the social and the economic burdens that you see in your communities, we can alleviate these if we sort of shift these paradigms. So in terms of who the messenger is, it's not me. It's not Tom Hanks. I love Tom Hanks. So Tom Hanks, should not, I'll give a more immediate example. In Illinois, Michael Jordan. I love Michael Jordan. I think throughout the state, people love Michael Jordan. Michael Jordan is probably not the messenger for this. It should probably be different stakeholders in these communities who are trusted and known and who have some of that cachet and respect built in that I'm not going to have because I'm not from rural Southern Illinois, these other communities. And that doesn't mean that as people who care about these issues and do the research and the programming can't have a stake, but we should not be in the front seat to lead these efforts. So in sum, to reduce some of the stigma that we're seeing across opioid use and drug injection, the emphasis can't be solely, I'll say, I don't want to say it shouldn't be at all on education, but it shouldn't be solely on educating people, but we have to connect people. We have to link them to what they already know and believe, to mentalities, evidence-based mentalities that promote this mutual understanding that are also creating these pathways and sort of this constellation of feelings related to empathy. Okay, so sorry, I apologize. I went over a lot more than I anticipated, but hopefully folks were able to stick around and I can take some questions here if people have them. Thank you. I'm gonna stop sharing my screen here. And Aaron, maybe you've got some questions to load up.
Okay, well, thank you so much for that presentation. You certainly offered a whole lot of information and generated a lot of comments and questions along the way from our viewers. So I appreciate everyone, all of your thoughtful comments and questions that you've been submitting. And I know that most of you have started using the Q&A box. So I'll just remind you, Q&A boxes, it should be at the lower right of your Zoom window, and that's a good place to stick in your question. And we do have a number of questions coming in. So for those of you who can stick around a little longer, we will spend a few minutes answering the questions. And also just to let you all know again, we will have a recording of this webinar along with a copy of the slides on the Maryland Rota website, which is marylandrota.org. And Dr. Ezell just posted his email in the chat box. So those of you who may want to follow up with him separately can do that as well. I know a couple of you were interested in copies of his articles and things like that. So I'm going to jump into the questions here. And we have one viewer who was paying close attention all the way along as you were presenting. And she actually sent us a couple of questions. And she noted that you had done interviews with about 30 professionals. And she was wondering how you went about picking those people and how representative you think they may be of the opinions in the broader population of professionals in your area. And also then what other resources or sources you may have used for information on rural opinions about stigma and drug use.
Sure, absolutely. Those are great questions. So in terms of how we selected the list of stakeholders, a lot of that was curating these lists based off of the stakeholder groups that we felt like these are going to be people who know what's going on. So we say law enforcement, yes, because they're going to the homes, right? They're getting those 911 calls that somebody overdosed, EMS. These are people that are going to have these regular interfaces. So our levels of communication, honestly, it was a lot of cold outreach. It was a lot of me just like finding people in these different communities, looking up email addresses or phone numbers and reaching out and say, hey, we're doing this project. We really like to speak to you. It's confidential. We just want to know how you think about X, Y, and Z in terms of these different things that we're interested in. And I'm sorry, what was the second part of that question? I should take notes.
The second part of that question was just about what other sources you used for getting information on rural perspectives on drug use and stigma?
Yeah, so I'll say, so I should definitely acknowledge a lot of the collaborators on my project. So Sam Friedman, who's done work probably for the last 20 or so years related to injection drug use and sort of opioid use in general in New York State, was a big leader for this project. So a lot of our sort of paradigms for how do we approach this, how do we think about stigma came from him. Also, my mentor some years ago, Bruce Link, who developed a really robust framework for conceptualizing stigma, gave us some ideas for how we might think about some of these things. So from those interactions, we start to just get exposed to more and more of the literature. And for us, we're thinking like, there's not a lot of value in just going out and publishing an article or just doing research where it's like, yeah, yes, where there's stigma. There's stigma in rural communities, like many people know that, but what's the extra level of depth that we can get? So instead of, and arguably, and we have also had these interviews, I should mention, with people who use drugs. So it's not just like, it would be very strange to say we're doing this study, we're just talking to stakeholders. We don't care whether or not, people who use opioids actually experience stigma. So we adopted this idea of like, let's start with the stakeholders because they're going to give us some insights that then in a follow-up, we can start to talk to some of these other communities about. But from sort of the more theoretical and conceptual end of things, we built a lot of that from some of the researchers on our projects who've been doing this work for some years. And we just landed on this idea of stigma can be many things, that is fluid, that it's adaptable, but whatever it is, it has these downstream impacts that people aren't always entirely cognizant of. So hopefully that clears things up a little bit more. But there's a lot of really great research. Corrigan is somebody who's doing a lot of really great research in this space. I've also noticed, which makes sense because there's a lot of synergies between sort of the mental illness research space and the opioid use or drug use space, is that you have people who are doing research on stigma against mental illness who are now making a pivot towards research on stigma against opioid use, which I think is great.
Okay, thank you very much. And so we also got some questions from viewers who were looking for some practical advice about what to do about some of your results. And so there was one question here that was, how do I speak to those in positions of authority and pivot the conversation away from prevention and harm reduction are enabling to prevention and harm reduction are helping society? For example, those in law enforcement or EMS.
Yeah, I think the tide is certainly turned against us in terms of the burden. I think I don't want to overstate it. And also keep in mind, I want to acknowledge that something people are aware that this was a qualitative study. We spoke to 30 people, and I should have given more of the percentages of who we spoke to, but we're talking about speaking to 30 people how representative are their views of other people in their respective departments or organizations, and how do you extrapolate that out to say, okay, this is rural Southern Illinois, does this apply in Kentucky? Does this apply in Oregon? Like we really don't know the answers to that. What I would say though, in terms of like the application, is that this is something that we've had to think a lot about. So as a practical matter for our work, we sort of just spoke with some of the stakeholders who were amenable to the idea of harm reduction. We applied for this grant within the agency and said, like, we're just going to do it. So we know that there's misgivings in the communities, at least from the stakeholders about this, but like, we're going to make this effort to expand these services in these communities. And I'm not suggesting that you go into the communities I've even been in and say, hey, we're going to start building up, harm reduction facilities here. You certainly shouldn't do that. But we had the conversations. I'll also add to the person who brought that comment, we created community action or advisory boards. So these are people in the communities, a mixture of stakeholders, a mixture of people who use drugs, who are helping us formulate these ideas. So we could say like, okay, here's what the data looks like. And then we could turn to a person who used drugs on that committee and say like, so how do you think about this? Like, does this sell? Does this work? But I definitely don't think that there's a one size fits all approach to it. But I do think that for us moving forward, because we've encountered so much resistance, I'll say conceptually to what we're doing. I should say it's not conceptual, it's more practical and applied, that we're still trying to fine tune and figure out what the right message is. So for our ecology ecology, I believe that the message is about cost effectiveness. We haven't piloted that yet, but just some of the initial runs that we've done, it seems to be a powerful message for people. But yeah, to the more everyday communication, relational dynamics, and how you have that conversation, I do think that's very tricky. And I also want to make a point, not to be too pessimistic, because I do think there's a lot of things to be optimistic about, but there's also to be a case that some people are just very entrenched in these ideologies. So to go and say, this person has believed this for this X number of years, that they're not going to shift, at age 75, right? Like they've gone on this track, it's not going to change. So that does make things pretty daunting. And frankly, in a lot of the communities that we're in, this is the old guard. So you do have a younger crop that's coming up to say, yeah, we believe in being culturally sensitive and trauma informed. But that doesn't change the fact that the people who are pulling the strings have very strong antagonistic views about all these things.
All right, thank you for that. So there's a couple questions here that are related to finding a new way to shift from a focus on changing language, like changing the terminology, like you talked about in your presentation, to starting to address the underlying and sometimes even unconscious beliefs and behaviors that people may engage in that result in stigmatizing people who are using drugs. And so they're wondering if there's things that can be done through education or other approaches to address this.
Absolutely. I think that's a great question. So one thing that I do a little bit of research on, and that is a focal point for one of my courses, is implicit bias, which I feel like this is sort of maybe what was being articulated or being approached in that comment there. So I do think that there's a role for implicit bias training. And I do think like the whole tenor of and the tone of what is your intention here? Like, if you believe this, does this make you a person who hates people who use opioids? If you believe this way, does it make you a racist? Does it make you misogynist? Does it make you homophobic, xenophobic? Like, there's a lot of complexities that go in there, and I think that's probably better suited for a social psychologist. I think it gets very tricky to sort of pick out like what is the optimal language to start to engage with that debate. In our experiences working with these populations, we know that certain messages appeal to certain types of populations. Like, that much is very clear to us. And so also keeping in mind with our sample that like law enforcement is very different from healthcare providers, or very different from social workers, et cetera, et cetera. So I think it's complicated. I don't think that it's not workable. But I think there's a lot of layers to it that we haven't really digged into, because we're sort of not just arriving at the point to know that we have the issues, and we're starting to look beyond some of these structural things to say, what are the more behavioral aspects of this that are creating these issues between people? So I think the big thing with implicit bias trainings, though, is yes, we know that at least on paper, they sound pretty good. Like when you do these trainings, and if any of you ever have time, Harvard has, it's called the Implicit Association Test, and it takes you like 40 minutes. And it is a gauntlet. Like, it takes a long time to do. I don't know if the predictive utility of it is, but a lot of people will do it and say like, so what do I make of this? And I won't even explain what exactly goes into it, but suffice to say, it's a test that's supposed to gauge whether or not you have implicit biases, maybe towards particular groups or types of people. So I think what I came out of, and what I sort of feel like is the wave of the literature, is that like, how do you really measure implicit bias? And most importantly, if you detect that there are these implicit biases, it doesn't matter that much if there's no real recourse or follow-up for, not changing those practices. And who within an administration or department is going to take the time to track John from point A to the point C that he needs to be at, so that he's a little bit more culturally sensitive and culturally congruent? So I think the most important things for this, and I'm not sure a lot of this has been done, but it's something that I thought about, is like, how do you measure it? And if you don't meet that standard, and I'm not trying to be overly punitive, like you go and fire somebody because they fail the implicit bias test, but it makes you think about, how do we keep people accountable? if we see that like some things just aren't clicking when it comes to this. So I don't see implicit bias testing as a panacea, but I do think it can be powerful. But if we don't couple that with some level of follow-up, like, okay, you did this training, we know this and that. Are you improving on these metrics? Are we talking to your patients and they're saying they're improving or not? Then what's the point of doing these implicit bias trainings? It's just very performative and it has no value.
All right, thank you very much. I have one last question that I'll throw out today, and that is rural folks, including stakeholders, may feel stigmatized by virtue of their rurality. How might this contribute to the complexity of their own enacted stigma against people who use drugs?
Oh, I really like that question. All these questions have been great. So I think there's a point about identity, which I tried to get to in one of the last slides about there's a shared identity in these communities in ways where you may not see in an urban area, where urban or suburban, where you expect a little bit more social, ethnic, religious diversity, just across the line, like sexual orientation diversity. And not to say that racial rural areas are monolithic, because they're not. And actually, we're increasingly finding that they're actually fairly diverse. But I really like that question because it gets us to think a little bit more about like, how do they see one another? Is there a little bit of this identity preservation that's going on? And one may make the opportunity, like just from the jump, like if you live in a rural community, is that stigmatizing in and of itself? Like if you go and tell somebody that I live in, you know, wherever in Appalachia, right? Somebody's going to look at you and like, it may not be the whatever, like you're in the backwoods and it's a whole deliverance sort of thing, but there could be a dimension of it which still feels a little bit of stigmatized, like, oh, like, what's that like? Like, why would you want to live there? I'm from Flint, Michigan, and I get that. And Flint, Michigan is not a rural area, but like, depending on your geography, like it's not uncommon for you to get that sort of language. So I suspect that everybody, not everybody, but many of these people in these communities, they're very aware of how they're perceived, even by us as academics coming in. And I think this definitely has an impact on how they perceive one another. And you could even argue that it's a little bit of competitiveness, like it's competition for social identity in this limited space. Here's sort of the ceiling of what we can be, and here's what I'm going to shoot for. And you're not going to shoot for that. So as like this collectivist sort of thing, like you're dragging us all down by doing what you're doing, you're giving our rural area a bad reputation. Like I don't want, as an example, one of the communities is Carbondale. Like you're giving Carbondale a bad reputation by doing this. When I talk to my friends, like I'm from this community, they think we're all like you now. So I think that's, again, I think that's a really salient question and point. I don't think there's been a lot of research around that though, but I would say identity is really at the center of that sort of question.
All right, thank you so much. And thank you again for a great presentation and a great discussion afterwards, fielding the questions and comments from our viewers. And I'm glad to see that so many of our viewers did stick around for this part. And I hope that we will see you again at our next webinar. We have another one coming up this month in July. It's actually on July 21st at 12 p.m. Eastern, and it will feature a presentation by Dr. Casey Pinto, who will be presenting on her research comparing overdose trends and drug overdoses in urban and rural areas. So that's filling up fast, but I hope that you'll be able to join us for that. And I'm sure there are additional questions and comments for Dr. Ezell. So again, feel free to contact him at his email, which he shared in the chat box. And you can also get in touch with us at Rhoda, and we can help connect you to him or get you any information you may need as well. So thanks again, everyone, for joining us today, and we look forward to seeing you at a future webinar.
Thank you so much. And I appreciate you also bearing with me for that extra 25, 30 minutes there. So much appreciated. I love the discussion. Thank you so much again. I gave my email. I'm really content with this engagement here. So thank you all again.